Thanks again for everyone for joining us for today's webinar, Adjusting to Changes for COVID Test Reimbursement. There are a lot of potential questions surrounding this issue as we approach the possible end of the COVID public health emergency. So hopefully we can provide some answers today. My name is Alex Mitchell, and I'm a communications manager with the Lighthouse team. I'll be serving as your host today. I'd like to quickly introduce both of our expert speakers today. We have Ann Lambrix, a Vice President of RCM Consulting for Lighthouse Lab Services, and Janine Robertelli, CEO of Catalyst RCM. So I want to say a huge thank you to both of them for joining us today and sharing their expertise. For a little bit of background on both of our speakers, Ann serves as Lighthouse's Vice President of RCM Consulting. It heads up Vichette's day-to-day operation, which is Lighthouse's RCM consulting arm. With more than 20 years in the medical insurance and billing industry, her experience provides an insightful analysis of revenue cycle and payer trends impacting reimbursement for pathology and laboratories. Janine Robertelli is the CEO of Catalyst RCM. Prior to founding Catalyst, Janine was the CEO for a technology and revenue cycle management company, where she led both strategic growth initiatives and operations of the company. Prior to that, she spent years as a criminal prosecutor and civil litigation attorney. So again, thank you to both of our speakers. A bit about our companies real quick. For those of you who joined us before, this won't be anything new, but with almost 20 years of experience, Lighthouse Lab Services has become the nation's leading and most trusted end-to-end full-service medical laboratory consulting and recruiting firm. Vichette is a laboratory and pathology consulting firm specializing in revenue cycle auditing, refining revenue cycle processes, and negotiating managed care contracts. By specializing and working exclusively with laboratories and pathologists, our team has insight into industry trends and key payer issues affecting labs today. I'd also quickly like to take a moment to highlight Medical Laboratory Professionals Week, which is coming up at the end of this month from April 24th to 30th. It's a great celebration and something our company always enjoys helping promote as a way of increasing visibility and the vital role our industry plays in the patient care process. As part of this promotion, we're offering free stickers that are built from around this year's theme of Back to the Lab, clearly a play on Back to the Future there. And if you'd like to request one of those, you can feel free to follow that link on the pop-up form or follow up with us after the webinar. Now, a bit about Catalyst. Catalyst RCM is an analytics-driven revenue cycle management company providing medical billing, medical coding, and business analytics solutions to healthcare providers across the United States. They are dedicated to providing their clients with visibility into their business so they can influence and advance their standard of care. And with that, we'll go ahead and get started with the webinar, and I'll turn it over to Ann.
Thanks, Alex. The Lab Week sticker's still up. I don't know if I need to do anything to get rid of that. I'll just close out of that, but it's very cool.
You can exit out on your side.
All right, I got it. So I'm going to tease Alex here for a minute. I don't think, Alex, you've seen any of the Back to the Future movies, which is, you're going to have to watch them. But
I was born in 1990. I just missed it. So not to age you
yeah,
or, but
so
I'm getting up there
I
myself,
appreciated to find out that Alex hadn't watched those. So yeah, that is something, his goal. He's going to watch those Back to the Future movies, and we're going to have a sit down discussion of the wonderful the lessons that can be learned from there. I'm just kidding, Alex. But anyway, we'll go ahead and get started. Again, appreciate the time to talk to everybody. There's a lot going on. I've been telling my team, gosh, it feels like March 2020 again, where just all the things that are coming out, just trying to understand the new rules, regulations, staying on top of what's happening with COVID, public health emergency, new policies, procedures, audits. We've got a lot on our plate, and we have had a lot on our plate the last couple of years, and it unfortunately doesn't look like it's going to get any easier. Just a quick background, as we're all most likely very well aware, because of COVID and the public health emergency, a global pandemic. The federal government put in several policies in place to help labs get paid for their testing. Um, Pretty much, I say easy payment. So compared to prior to COVID, again, with COVID testing, insurers were required to pay with no out of pockets. We weren't looking at high deductibles, and claims were submitted, and most of the time got paid as they should, in full. There was a HRSA fund. HRSA is nothing new, but they did utilize that program to pay for patients testing if they had no insurance. So again, no insurance, no problem. We had a fund set up to get paid, and again, there was a process involved, but once everybody learned that process, pretty easy to submit, get your ID number, your temporary ID, get paid. Um, Sorry. And out of network challenges, again, prior to COVID, and for labs doing various testing, non-COVID testing, out of network has always been a challenge for smaller labs, and trying to get in-network payers, trying to get paid as out of network, again, pose many challenges with COVID. I know that you may have seen some out of network challenges, but it was limited, right? So we've been living in a little bubble. The last couple of years, there's been a lot of protections put in place to allow for easy reimbursement, or hopefully most of the time easy reimbursement for COVID testing. And unfortunately, we do expect that to change at some point. Again, I wanted to just quickly touch on, I mean, everybody should be very familiar with the FFCRA and CARES Act, but one of the things I think is always important to point out, the FFCRA is the law, or the bill that was established to ensure that the patients, um, uh, the insurance companies would be reimbursing for patients with no, again, out of pocket, no prior authorization, other medical management requirements. And so that FFCRA was established to extend through the public health emergency. So, which, as we all should be aware, is set to expire here in a few days. Alex, to confirm, it's April 16th or 17th?
16th.
Okay.
That's
All right.
correct.
So we do anticipate, and we'll kind of talk further. We do expect that it will be. We have a hunch it will be extended another 90 days, but we're not 100% on that. And so again, these discussions of what happens after the PHE is lifted is really important to start having. Whether or not the public health emergency gets extended for another 90 days, again, the continued extensions are going to be limited. And so we need to start putting some things in place. CARES Act also, again, that's where plans and insurance companies should be paying, whether you're in or out of network. And so these are just, again, a couple of the umbrella laws that were put in place to help labs get paid. And we expect that those will at some point go away. As Again, this is a very timely discussion because we've seen where HRSA, the uninsured program, we got notified like, oh gosh, a week before they decided that you were no longer going to be able to submit claims through the uninsured portal. You got a notification, everybody scrambled to get everything submitted as quickly as possible. And at this point, no news. What are they going to continue to fund? I know that there's been a lot of lobbying in place to try to get additional funds earmarked for this program. But again, keep in mind, I mean, at some point these funds will dry up and they will not be replenished. So it's the end is near for this uninsured program. The other thing is, again, more delay. We're gonna, I know I've worked with lots of labs where in the past we've seen where there's been delay and then you get a bolus of payments. Most likely because they're running out of funds, you're not going to see timely payment with the remaining funds.
Real quick before we move on, Ann, I did want to throw a question to Janine. Janine, have your clients still been seeing any payments from the HRSA fund, or are those on hold completely across the board right now?
Well, interestingly, we've actually seen some opening up of that, but it's only been since the deadline for the vaccinations. So once April 5th passed and people submitted all of their claims that they could submit, we started to see payments open up a little bit. We had not seen I would say some clients hadn't gotten payments in 45 plus days. And when we started following up on payments prior to that April 5th, we were told it could be as long as 90 days from the time of submission. But in the past week, I would say all of our labs have gotten some payment. And so that is a good sign. Now, those payments are probably on about a 45-day delay from the time of claim submission. So certainly not fully opened up. And as Ann says, I think that they're trying to use what funds they have left, which is why it didn't surprise me that they waited to see what those claims would look like up through April 5th. And now they can evaluate the dollars that they have, the dollars that they want to recoup, to maybe spread around a little bit more. And I think we'll talk more about that later. But yes, to answer your question, people are getting paid.
Real quick, Janine, since we're on this topic, I think it's important. What are other labs doing as far as, are you seeing where even though they're not accepting new claims through, what are labs doing right now in this kind of we're in limbo trying to figure out, is there going to be additional funds allocated to this program? Do you see anything that a common scenario or trend?
Yeah, I mean, I think that you're looking at two things, right? We have the go forward plan, and certainly everybody is now put on notice that we don't have the safety net. And so if it returns, great. But I think even then we know it would be limited. So I think a lot of labs in their go forward program, their kind of first knee jerk reaction was, this can't be real. Let's continue to provide services for the uninsured. We kind of, have a flow of business here, but quickly that seemed to change. I think a lot of people are saying we have to find either a cash pay rate, there has to be, some promise of payment for the work. And of course, then I think the bigger issue for some is that they maybe weren't able to get in all of their claims. They may have been on a delay. And really, I mean, my sympathies are with the labs that met the response of this pandemic and kind of got the assurance, you meet the operational needs, you meet the pandemic needs, provide for this, and we have you covered. Like I said, we've never seen this before where anybody's so willing to pay you. So I think the response to that look back is that if a temporary ID was not given, and they may have been applied for it in the end, not given, and they couldn't submit the claims. I think that one, labs may be choosing to hold on to that with some hope, but I would emphasize that there are, services out there available to see if maybe something you're thinking is uninsured might actually have insurance. And we've been told that, that sometimes a patient has said they're uninsured and they're not. And we should all know that, right? Because we submitted for a temporary ID, and sometimes we got the information back, yes, there actually is insurance. So you may need to go a few steps further or even invest in that. I hate to say to invest a little bit more, but invest a little bit more to find out if those patients have insurance and try to do some, kind of mitigation of damages on your own.
Right. And again, we'll cover a little bit more as we go through the slides, but there's Medicaid. I believe there's 15 states where there's additional funding allocated to Medicaid. And so there may be, like Janine said, additional options that we can explore. And it's really important, and will be very much stressed throughout this webinar, is start having these conversations and thinking about, again, what's next. Because we're at the point where it's time to start thinking about what's next.
Yeah, and I think just real quick there, I mean, your point is good about Medicaid, and maybe that's a coverage option. I've also seen some states that set up initially a similar type program where it wasn't federally funded, but it was state funded, and maybe you already signed up for it and you just weren't taking advantage of it. Now that there may have been a deadline, that may not be a go forward option. But keep looking. I mean, I comb these websites every night and just, put in key search terms to see if anyone is providing relief. And I think that there's some information out there that might be able to help you.
Right. Again, audits and policy limitations. This is where we're at the point where I know Vachette has stressed since the beginning. At some point, we're going to see HRSA and these insurance plans starting to audit reimbursement, what they've paid out for COVID testing. Again, easy payment. I was just listening to the radio this morning. We were talking about, there's no such thing as free money. We'd say, as far as easy payment, we kind of all smile and snicker. It maybe have gotten paid up front very well, but we do expect that there will be some audits and some recoupments in the future. And so additional work will be placed on the labs to keep that money. I know I just
And
jotted down. Oh,
before
go
you
ahead, Janine. Yep.
Sure. Yeah. Just before we move, I see the next point on the slide. I think that is an important to note is that although we have seen payments, we've looked closely at those payments and already seen some recoupments happening. And so, that's going to be an important point. Stick close to your biller. If you have a good billing partner, they should be able to tell you whether or not you're also getting recoupments, because you're looking at a total dollar amount with relief and not realizing if there's some, slipping off into recoupments. And again, you might have options on that. I could only guess that if this isn't like a full-blown audit, that they've discovered insurance on that patient. Maybe you have some options, but definitely be aware of it. I know at Catalyst, when we post payments, we keep track of those CART codes, and we're able to, with the reason code, give that recoupment information in real time when we post payments. But even if it takes a little bit more digging, those are questions that your biller will be able to answer whether or not you've had recoupments, but you want to maybe be aware and ask the questions.
Yep. And so with that knowledge, again, you can be more proactive than reactive. If you start seeing recoupment and potentially be at risk for bigger audits, that's where it starts in the recoup. So again, having those conversations and that knowledge up front is really important. I
Sure,
just
I've got a
jotted
lot
down,
of.
Janine, I just,
Oh,
one of the things I jotted from some of the research that I did was that, these, again, HRSA, for example, maybe auditing past payments in order to recoup some of the funds to pay out the new claims that are coming through. Again,
right,
the funding's out. There's no more at this point. So they're going to be looking at
right.
what's been paid out to see if there's additional funds that can be applied to new claims coming through. So again, labs need to keep that in mind.
Right. For example, throughout the pandemic, when, it's always a difficult decision, right? You flip something to HRSA. Have you done enough to meet your requirements of making sure that this person does not have insurance? And I always felt, documentation was key to that. Just like so much of what we do, so that, if you were using a mobile app or you were having somebody fill out, information through their clinic saying that they were uninsured, if you start to see a problem, keep track of that documentation, because you may need to provide that to show that you reasonably relied upon the patient's representation. Even if they have insurance, you want to be able to always show that you acted reasonably under the circumstance. Now, if you just wholesale, realize that your drive-through on Christmas Eve got too busy and nobody collected insurance and you flipped it to HRSA, obviously I'm just giving some random example, but in that case, you may want to go back and self-audit. You may want to see if you could do some discovery and identify some that you got paid for, that perhaps there was another solution, and head it off. Just a thought, depending on how much you see in the way of recoupments.
Right. Again, and these are just, we're starting to see where it is very important for labs to make sure that they have been, and if they have not been, start with really good due diligence to prepare.
Okay.
The other thing that we're seeing, again, these are things I'm not surprised, but with COVID, I saw a lot of labs start bringing in the PCR, the infectious disease, respiratory, and then there's other respiratory, UTI, wound, and that was a good next step for them because of the COVID testing that they were bringing in. We are starting to see where payers, let's start with Medicare, for example, is starting to really crack down on the reimbursement of these infectious disease and other types of molecular and genetic testing, simply because, again, the way I look at it is as we see these testing develop and we see it become more standard of care, labs are starting to bill more. It's becoming, again, there's a flux of these types of charges coming through, and so they're going to start limiting, again, reimbursement, being more restrictive on the medical necessity implications, what they were willing to pay. And so um, it will, it, things are going to be tightened. For example, with the respiratory pathogen panels, again, in the past, we've seen LCDs in place that restrict the number of pathogens that they consider medically necessary, which is the 3 to 5 targets or 3 to 5 pathogens within that panel. What we've seen recently is that the states that are within that MolDX platform are now issuing guidance for infectious disease, where they are going to be requiring those Z code. Z code on the claims. You're going to have to apply for the Z code, go through the technical assessment for infectious disease. So extra steps will be needed to get those tests approved and reimbursed. Now there's only, there's 4 MACs within the MolDX, Palmetto, CGS, Noridian, and oh my goodness, I always forget the last one, but WPS. So those 4 MACs have all issued this policy regarding infectious disease. However, I do expect that Novitas, NGS, and First Coast will start issuing similar. Again, because of COVID and what we saw as far as a trickle-down impact with COVID testing and the development of the molecular testing, we've seen a lot of labs move into this infectious disease because of COVID. And so now the payers are starting to really tighten up on things. So even though if your lab is not within those 4 MACs that I listed, part of MolDX, expect at some point policy will be issued with Medicare, and we'll start seeing the commercial payers issue similar. So again, what our main point on this webinar is start preparing. Understand what's going on with your reimbursement, start doing some due diligence and making sure that you have the appropriate setup. Again, are you getting a Z code? And Alex had indicated Lighthouse does have a process to assist labs if you do need assistance in applying for the Z code, going through the diagnostic exchange, completing the technical assessment. We can assist. But it's important that you understand if your testing requires that. So again, we can guide you on that. Billers such as Catalyst should be able to advise you on that as well.
I mean, I could not agree. I mean,
Yep,
I think
go ahead.
PCR obviously became the household name, which was a great thing when we started seeing it at first, and it makes sense why people would transition. But for anybody that's been in the lab space, it's the same story over again, right? When we've seen reimbursements that seem too good to be true, they usually are, and they're going to be pared down with medical necessity. And these are changes that are happening in MolDX like in the next 10 days. So again, I can't emphasize enough really sticking close to your billing information. And if you are already running these panels, finding out if all of a sudden you're not getting paid for them, because there's steps that you're going to have to do. And like I said, Lighthouse does a great job to be able to help you work through that process. It seems daunting to apply for these codes, but it can be done, and it needs to be done if this is your future.
Right.
Real quick for our panel, while we're on this subject, since we won't be returning to it during this webinar, we have a question for roughly how long does that registration process for the Z code take?
So you first have to register your lab on the diagnostic exchange, which if you've already done that, that's good. But to just get your lab registered, it could be up to 2 weeks. And that's why we're saying at least complete that now. And then for the technical assessment, I'm hearing 30 to 90 days. And the technical assessment must be completed in order for that Z code to be assigned. So, again, we are here to help you through that process. We're working with it with the labs that we work with, and so I'm expecting, again, more information as we work through these with labs. This is a brand new LCD policy, something that, as far as getting these infectious disease in the Z code and doing the technical assessment, again, I'm hoping it's more on the 30-day end. But because all these labs are now, registering for these Z codes, we're expecting there may be delay just because there's so many that will be working through this process. And again, I just kind of jotted down respiratory COVID. So, I really think a lot of labs went into, because they were doing COVID testing, they developed a respiratory panel, and it made sense. And so nothing that you have done is wrong, fraudulent. It's just what we're advising is that the good old days of getting paid well on this is, unfortunately, we're expecting that will go away. Doesn't mean that you cannot get paid on this, just going to be a little bit harder. On the silver lining, I do like to mention the MolDX program. What I do like about it is that once you do go through the technical assessment and get that Z code, they also assign a CPT code, and they link the whole part, the test, and it's almost like a pre-authorization. So I believe that it will eliminate a lot of that back end denial. Janine, do you have any clients that you're billing for genetic testing that are using the Z code?
Yes, we do.
And do you
And
find that
I
it
agree.
provides at least an ease? Yeah, an ease on the back end. So again, what we
Correct.
see as far as all these denials and having to submit the medical records to support, like once you
Right.
go through that process, it's more of a front end process. So it does reduce that back end, and you get paid what you're, even though it may be a little bit less than what you were getting paid with the coding methodology that you were using before. At least it somewhat streamlines the payment.
Right, and you get the payment sooner, and it's difficult to keep on top of. Again, I mean, we have a client that is not in MolDX, like you said, but they're routinely getting denials for most of the CPTs, and if you're not on top of it, you're really getting underpayments over and over again. Now, if you go through the effort of appealing and submitting the medical records and the documentation, but you could be 60 days out in payment. So I agree. The certainty is a silver lining, and being able to, predict what your payments are going to be ultimately, right? Medicare is a reliable payer
Right.
when you're meeting their requirements. So I agree.
Right. Yep. So that's why I'm trying to look at this as with the silver lining. I know that there's a lot of fear out there with going through this process, and it is some additional steps. But I'm hoping that this will help not only get our payments more steady, but again, I also look at it this is that they are, once they start developing policy, again, they are indicating in the LCD, if you've looked at the language, they do find that these infectious disease, there is medical necessities. So they are starting to adopt policy to make sure that they're reimbursing. And we will continue to see as this testing starts to develop, and as I said, becomes the standard, we'll see reimbursement potentially go up. And I'm hoping there will be developed the CPT code. So when we look at coding and try to determine how to code out a UTI panel, we'll have a UTI a panel code. So again, it go
Right.
back to the ease of billing and collection. So for us on the call, Janine and I, that's great. The ease of billing and collection. Labs, some labs may not know how much you are spending in the overhead to bill and collect for these tests. It's a lot. All right. So life after the public health emergency. So these are some questions that I've had, and again, I'm most likely you have as well. Once the public health is lifted, the Family First Coronavirus Relief Act no longer applicable, and I put a question mark after that. I don't think it will be. It is to cover payment for testing during the public health emergency. So I do expect, now it is set to expire April 16th. We feel that it's expected to be extended another 90 days to July 15th. Alex, our reasoning behind that is because they had indicated they would give a 90-day notice, and we haven't seen any night. Is that correct? Or 60-day notice?
60-day notice. So the administration had promised that there would be 60 days heads up before they allowed the PHE to expire. And while there haven't been additional announcements regarding that at this time, that is still the operating assumption, I think.
Okay. Um, Again, even if it is extended all, I really want everybody to be just very well aware this will not go on forever. So the FFCRA will expire at some point, and so we have to be thinking about what's next. COVID testing, patients plan benefit design will be applicable, and you may see some insurance plans already limiting their reimbursement and applying patient out of pocket. Again, really important that you have a hands-on of what you're getting reimbursed for your COVID testing. Billers should be able to provide that information. COVID testing, I feel like at some point, as we move from pandemic to endemic, it may be like a flu shot. So most patients' benefits do cover a flu shot per year. I expect that may be the same for COVID. It may be the same for COVID for a test as part of your wellness, or for a COVID vaccine as part of your wellness. And as far as a COVID test, it may apply to, again, your lab benefits, whatever that may be. I think it's been difficult for payers to really establish what they're going to pay. Simply because we've had so many waves. And so again, I feel like we've had this conversation back in June or July of last year. We really anticipated that the pandemic was going to be moving into the endemic. And then we got hit with 2 more waves within those 6-month period. So I've been hearing too that we're seeing where it's picking up in various states. I want to say Philadelphia just put in a indoor mask mandate again. So we may be in for another ride, but at some point, insurance plans will adopt policy and patients' benefits similar to other lab testing. And I do expect out-of-network restrictions will resume. We always see where smaller labs is difficult for you to become in network with larger plans. Especially if you're just doing, uh, tox or you're doing infectious disease. It's difficult. There are more narrow networks with the national plans. So
Eh,
I expect that to resume. Go ahead,
Oh, I
Alex. I'm
don't
sorry.
want to interrupt Jan, but we had a comment from Robert Henry
Oh
that
yeah,
said the PHE was extended, and he's correct. I see as of about 10:30 this morning, an administration
Right.
official announced that they will do that 90-day extension. So that
good.
will put us out to July 15th as anticipated. But I would be shocked personally if we saw another extension. So look for this to be the wind down period that everyone's been discussing.
Hmm.
Thank you, Robert Henry, on top of
Yes,
things.
yes, good. Any additional comments, Janine, on this?
No, I just think you're completely right. I mean, even like the one thing I just kept thinking about is the CS modifier for cost
Hmm.
sharing, that up through now we've been able to not have like a patient responsibility. And I think once the public health emergency goes away, that, the guarantee of that goes away. But again, like you're saying, Anne, does it kind of behoove the insurance companies to make sure everybody's getting their shot, getting their test, so that it may be included and it may not be. And it's going to be very not just financial class, but very plan specific.
Right.
And you're going to want to keep track of that. I wish that I could say more people were getting in network. It's hard for me to believe how many labs have done the yeoman's job of meeting the needs of the pandemic, and it's still difficult to get contracts. But
Yeah, I was really disappointed with that. I really thought with labs kind of moved to the forefront during the pandemic. I had expected that there would be more understanding of the importance of having access to care. And there may still be some uh, we may see that happen. But
right,
at this point, the bigger payers, we just haven't seen that move.
right. I mean, I say keep fighting for it for sure,
Hmm.
but I am personally just so disappointed. not that the public health emergency is coming to an end. That is good news, ultimately, but that labs were promised, if they met the need of the pandemic, that they would be taken care of. And, not everyone has been able to stay on top of their billing. We've had a lot of people come to us in bad shape, to be honest, and really to no fault of their own. It had a limited
Hmm.
internal team, or everybody was overwhelmed. And, unless you have kind of a software like ours that we can operationalize something bigger, I mean, who really planned for it? They just met the need thinking they were going to get reimbursed. And so I'm a lot disappointed that we're looking at the service in the past that may not be reimbursed. So hopefully they'll, reach deeper and find the funds for all of you to be paid for at least the work that you've done. But our responsibility now is to change the game plan and to be aware of what can happen, stay on top of our billing, stay on top of our trends.
Right. So that's kind of my final points is, so what's a lab to do? Um, I have always advised, I've been doing this for a long time, and it's very important to partner with those that can help you understand your billing and your revenue cycle. Um, Reimbursement by panel CPT code, if you're running a UTI panel, you really should you should understand, like, I can do modeling for you of what I think you should get paid, but you should have some sort of system to identify, am I really achieving that? And looking at your denial trends. So if I'm not getting paid, this amount, if I was supposed to get paid $400 for this UTI panel and I'm collecting zero, why? I work again with labs all over the country, and I'm always amazed when we come in and do an audit, and it's they weren't even aware that 75% of their business is getting denied because they're out of network with a payer. And then again, looking at your payer mix, if you're, a COVID lab moving into infectious disease and you've been working primarily with uninsured patients, or if you've been working with Medicaid or Medicare, it's really important as we move into life outside the public health emergency, you understand we're going to go back to some rules, and the reimbursement is not going to be as easy as it was. And so what does that look for me? What are the various payer rules for this type of testing? I say this all the time to my clients and to my team. When you're billing insurers, and we've got 7 different max across the United States. Every state Medicaid has their own policies. You've got commercial payers that every policy, I shouldn't say every policy, every commercial policy may be different. Just because they are United Healthcare doesn't necessarily mean that they're going to follow Medicare guidelines. And then you have the managed care, the HMO. So you have the Medicare and Medicaid plans that also may have separate policies when it comes to billing laboratory, molecular and genetic testing. It it is imperative that you look at your payer mix and understand, who am I billing to, and again, what are their policies in regards to paying out these claims, medical necessity, pre-authorization. Those are all going to limit your reimbursement. And so even though, again, I can say in a perfect world you should get paid this, it is very difficult for me to identify without getting that back end in, or that looking at that payer mix, exactly what some of your challenges may be. Finally, auditing your process. Everybody's going to roll their eyes. I'm very, very much, you really should be on top of your process. The OIG has an established the laboratory compliance. And part of that is auditing your billing process, auditing your patient billing policies, making sure, and again, especially now that we're getting out of this, we're post-COVID, we should be looking at pre-COVID policy and making sure that that's fitting within the compliant guidelines of billing and collection. And then I did put in front-end validation, especially with With COVID, we've seen where getting, collecting data and collecting patients' insurance, we've simply had to, basically click a button saying that I did the best of my ability to identify if the patient had insurance. That's going away. We have to get back to having better front end validation. What the patients, again, what their plan is. Because again, if you start looking at your back end denials, you may see you're getting denied for no coverage. Patient has another insurance, and your team is going to have to be spending a lot of time trying to dig for information. You really have to have a good upfront process to ensure that back end piece is running smoothly and you're collecting what you should be collecting.
Yeah, I mean,
Janine, I'm going to
to
kick it
both
off
of
to you.
your,
So if you, go ahead.
sure. No, I'm chomping at the bit just to say exactly what you're saying. I mean, with respect to the managed Medicaid, we have clients that are moving into infectious disease in new markets, and they don't really have an awareness of those payers. And we can show you, Alice, I don't know if you want to advance, or I can advance
Yes,
to the
yep,
next slide.
yep,
Right,
go for
there
it.
you go.
Yep.
And this is a piece of our operations dashboard, and here's our monthly collections by financial class. And so, for example, we're looking at just one of the KPIs. We meet with our clients weekly, and we will go over their specimen types. This is an example of a UTI new for them, and we're tracking where do you stand by financial class. And you can see we highlight Medicaid. Well, not all Medicaids are the same, to your point, Ann, and there's some that they're actually losing money on, and we can track that. We can compare what you kind of modeled for them initially, and then what happens in practicality. What does that payment look like? And sometimes it's disappointing, and other times, we recently, since we're looking at this week by week, we've said, we see you're getting a lot of this managed Medicaid and you're doing really well. Can you bring that to your marketing team and go get more of it if it's available to you? Where is it? And so it doesn't have to be bad news, but it's the importance that data is your friend. And in order to have, if you want to have revenue growth, you want to partner, and whether it be, you have Lighthouse bridging the gap between you and your biller, or, you find a biller that has this information, or just encouraged to get more out of yours, you need this information to grow in new markets. And so I think yes, it's taking that kind of real-time information and bringing it back to your process and your business model. And it's also doing some front-end work. I mean, we have put in, our software not only has the back-end data, but we work front end, and we try to give critical information with respect to insurance. Like, yes, does this person have insurance, but do they have benefits that will cover, let's just say, some sort of advanced genetics test? We'll find out at the front end, because some of these things are not stat. You have a little bit of time worked in. If it requires prior auth, get the prior auth. Don't rush to putting everything on the machine when you can put a process in place at the front end, and we help our clients with that. So I think that's, the one key point. I know we're coming up on the end here that I wanted to make. And then, this is just the way we've designed our workflows is, yes, the KPI report I just showed you a snippet of, we go over each week, but our clients have access to this data whenever they want in the dashboard. And sure, we can illustrate it. And some people love data and other people just like it spoon-fed to them. We do a little bit of both. But in this, you can see, this is operations perspective. We also have a financial dashboard, which we won't really have time for today. It's kind of some of the obvious stuff, your adjudication rate, your paid adjudication, what's actually hitting your account. But what we like to do operationally and financially is what you see in the graph across the center. And we're looking month over month. What is your claim volume? Are all of the specimens that you're running, are they actually turning into billed claims? Are they adjudicated? Are they paid? Are they zero paid? So you're looking at a month snapshot of what happened in that month. And we do the same thing from the financial perspective, because in the month of April, you might collect $100, but you might be collecting $100 for something that barely squeaked in under timely filing, and it's a 6-month-old date of service. You're not going to miss that here. And I think it was difficult for a lot of labs to find out that, their specimens run didn't match their billed claims, and all of a sudden they have to get everything in under HRSA. So keep track of that information. Know that things aren't slipping into, let's say, missing information. Everybody has it, but it should get better and better. So again, if you're moving into a new market, or you have a new clinic you're working with, and one of our KPIs is looking at the rate of deficiency at the time that specimen came in. And then we can give feedback and say, well, it looks like, this location or this rep is underperforming. What can you do to get them to get cleaner information the first time, and we'll get the claim out? Catching up is always hard to do. So I think, as we come to the end, I think my main points would just be it's difficult to fight a war on two fronts, and you're being asked to do that. Don't lose track of all the money that you've laid out, your lab has laid out for COVID testing, and do your best to get insurance information, get those claims in, keep track of whether or not HRSA is refunded. But don't assume because you're low claim volume on infectious disease that things are just kind of sailing along as they should be. There's a lot of changes and there's a lot of information that's critical to your growth, so you make the right decisions.
Thank
Thanks,
you. Thank you,
Janine.
Janine. And I just wanted to offer again, if anybody would like to follow up with Janine or her team to learn more about how Catalyst can help improve your RCM, feel free to follow that form right there. We're also going to have her general info email address listed here. So either way, we greatly appreciate Janine joining us today, and would love for you to follow up with her and her team if you have more questions. We are approaching the end of our hour here, and we'd like to give you a few minutes back for your lunch. But I do have a couple interesting questions that I'd like to see if we could tackle here. Going back to talking about the HRSA Uninsured Fund, what would best practices be if a lab found after a HRSA payment was made that the individual in question actually did have insurance? Would they potentially bill insurance and then refund HRSA, wait for HRSA to recoup and then bill? What do you think, Ann and Janine?
I would.
Mm.
Well, go ahead, Janine. Do you have
Yeah,
an
I
answer to that?
definitely would act on it. I would definitely act on it. I would have, it's interesting because part of me wants to say I would bill the claim and then give back the money. I would have some amount of concern that there would be a time in which I would have a duplicate payment.
Mhm.
So, and I feel like that's a little bit of a compliance quandary under a normal circumstance. I think maybe while this was kind of going on and people were less concerned about audits, I might say, let's make sure that insurance is real.
Mhm.
But I think you may have to see about voiding the claim and then billing to insurance, but being sure that there was insurance. What do you think about that? Do you
I
think you could do
agree.
the opposite?
I would validate the insurance, and then if you do find that the patient has insurance, void the claim with HRSA, submit to the new payer.
I think so.
Great, thank you. And a question here from Jeanette Gray, also regarding HRSA. With the HRSA funds depleted, are providers able to bill and collect from patients at a cash rate for COVID testing when uninsured? And I think that's one of the big questions we have, Anne, right? As long as the public health emergency is still in effect.
Right. I think from my perspective, and Janine, I really like you to weigh in here, but from my perspective, this is a conversation that I would have with my clients. I would look at my volume of patients that are coming through as uninsured, and then determining, is this something that you need to speak with your client on and say, we can no longer submit through the HRSA. We're going to have to bill the patient, or we'll have to bill you back. And having those conversations, again, I'd look at the volume and look at my top clients sending over uninsured, and then starting to have the conversation that we can no longer submit, and we're potentially going to have to bill the patient.
I'm comfortable saying that too. I know some people have a concern. They feel like, are you caught in between in a catch-22, like we're not allowed to bill the patient. But if you think about it, we've been billing patients when it's a travel scenario, when it's a screening scenario, right? That there have been these carve-outs or exceptions. And I think if there's no obligation to provide for free work, I think vaccines is a little bit different of a quandary when you have them already and it's the administration of the vaccine and now you're kind of stuck. But I think on the testing, that I agree with you, Anne, you'd have to put it up front and people have choices. And I think, I don't think you're obligated to give free services. And I think it would be a shame to not give any service at all to somebody that's uninsured, wants and needs a test, and you're denying them that because you're caught in that catch-22.
I
would
think
say
it
from
kind of,
perspective.
from my perspective, it goes back to, again, like charity care. Are we looking at patients that are truly uninsured, or they just don't want to submit through their insurance? And if they're truly uninsured, are we talking like, again, this patient is just coming in for testing because they want to test, or is there an order? Is there medical necessity? And then it's talking with your client. Again, it's either billing that patient and providing that option for a charity, like, a discount, and working through that like we would do in the past. Or again, going back to my client and saying, like, for these patients, if these patients have to be tested, we'll work out, again, a cash price with you, and you can cover it, or we're going to have to bill the patient. And before I just start mass billing patients, I'd really start having those conversations with my clients so that they're not getting caught in the middle between, a patient and you.
Right.
All right, I think we're going to wrap up here, but I think I have one final pretty easy question going back to Moldex and diagnostic exchange. Would you recommend preemptively registering for the diagnostic exchange, even if the MAC isn't requiring it yet?
I don't, I would say no. I don't even know if you can. That's a good question. If whoever's answering that or asking that question, if you could send me a side email, that's something that we can follow up with and verify if that's something that you can even do. Um, I don't think it's necessary to do. I just would be very cognizant of the fact that these policies are coming out fast and furious. And I know, Vachette, we try to stay on top of them. And we're it is difficult, the speed that they're coming out, and so
Yeah.
be prepared. I don't know, Janine, do you know, I mean, like, is that something that you
No,
would
I know
recommend?
the answer. I agree with you. I would tend towards thinking you couldn't do it in advance. Of course, we could follow up and get you an answer, but in terms of fast and furious, completely agreed. Our VP of Revenue Cycle she's loves this stuff, as Ann, and that's one of her nightly research jobs. She's taken upon herself is to see when are they going to extend it, because we don't think that there's as much time built in being with the swift action on MolDX on this. We think that they're all headed that way. That's
Yeah.
what we've seen.
Yep.
In other spaces. I mean, if you just kind of think back to the introduction of the G code for toxicology, you think about PGX, being limited to the specific medication gene interaction. I mean, this is all a push towards medical necessity. So I don't think the rest are far behind.
And I know we're limited on time. I just wanted to mention, like, one of the things I would recommend doing is looking at the size of your panels and making sure you understand, like, what the payer doesn't want is these large infectious disease panels. If you look at the coding and you again look at the LCD for the MolDX Max, it really is talking about, again, the 3 to 5 targets, 3 to 5 pathogens. Anything else is called the, oh my goodness, the extended panel. And so there's certain medical necessity requirements to do anything greater.
Right.
So again, if you're in non-MolDX, then I would assume that at some point, I'm sorry, it's called the expanded targeted panel distinction, and that's greater than 5 targets. So if you're running 22, 25 pathogens and you're in Novitas, for example, just be prepared that reimbursement's going to be cut significantly. So start working on a smaller panel size if you can.
Which is relevant, and I know we're ending to the question about should you apply in advance. Well, maybe not apply in advance, but like you said, start thinking this is where we're going. So now all of a sudden you have not validated this gigantic panel, and you have a chance right now to think about coming into compliance. And it's really no different than over the years of people saying, when I would say, well, you have to reflex testing for toxicology for Blue Cross, and you can't really bill everybody a full panel, and everyone would say, well, that's just the way it's run. So we're really only confirming just a few, but we're billing for all because how we run it. Well, they're letting you know in advance. That's not okay. And you can't build a blood wellness panel that tests someone that has no symptoms of thyroid for thyroid, because we really only pay for sick or diseased patients. There has to be a support for it, and that's how they're asking you to design your panel. So I wouldn't be afraid of it. Get the help that you need. It's a great area to be in, and it's important. Infectious disease is important, and I think that diagnosing these things early are that's not going away, and I wouldn't be scared off.
Right. Good.
All righty. Well, Anne, Janine, thank you both again for your time. We greatly appreciate it. This was very informative today. I apologize to anyone whose questions we didn't get a chance to address, but please reach out to either of those email addresses or the forms that were popped out earlier. If you have additional questions, we are happy to help you get those addressed. And just want to say thanks again to everyone, and we look forward to seeing you again next month.
Thank you.
Thank you. Thanks for including Catalyst.
Yep. Bye-bye.
Bye-bye.